welcome to today's NLN sponsor series with Eros Medical. I am excited for this webinar, some really great information with amazing speaker. I'd like to introduce first Adi McKenzie, who is a clinical advisor with Eros Medical, and thank you to Eros for being a silver sponsor this year for the NLN.
We are so proud to be supporting the NLN and to be presenting this very important and interesting webinar today with my dear friend and inspiration, Linda Ann Kahn. I'm sure most of you are familiar with her important work with aromatherapy and lymphatics over the long time. I won't go into details, but I know that there is so much information to share today that I'm not going to get deeply into her accolades. I want to say very briefly that Linda Ann and I attended a fascia World Congress here in my new hometown of New Orleans this summer. And when she presented this information, there was not enough room to allow everyone who was interested into the room where she presented. It was so exciting to really feel vindicated that our work as manual therapists, when we address the fascia, is extremely important for improving the lymphatic wellness of our patients. So with that, I will turn this over to Linda Ann and look forward to all this information.
Thank you so much for inviting me, and it's such a pleasure for me to be sharing my passion with you all. It's been decades now that I've been in this profession, and the last maybe 5-6 years that I got very fascinated with fascia and saw the connection between the lymphatics and the fascia. And when I presented at the fascia conference, they all knew about fascia, but they wanted to know more about lymphatic. And now I'm speaking to my people, to the lymphatic people, and sharing about fascia. I do just want to say that there are going to be some slides that have a lot of material, and rather than leaving them out, I'm just going to let you know, please take a picture. I will be giving you a PDF of those slides afterwards. It's too much information to go over in this, but I wanted you to see this because I did do a lot of research. And so that I want to just tell you that don't be frustrated because I will go quickly over those particular slides. We're going to cover the lymphatic system, the fascial system, the connection of the two, and connective tissue disorders, and in particular lipedema and Derkham's disease, which are my specialties and need so much attention, and how the fascia is important in these connective tissue diseases. And then how myofascial release and manual lymph drainage is helpful for this, and the fascia's role in connective tissue diseases. So we all know what the lymphatic system is, and we know that it's a network that runs parallel to the bloodstream. And we know that the entire lymphatic system ends up at the clavicle into the bloodstream, and it is a closed system that starts in the tissue and ends in the bloodstream, and it drains the larger collecting lymphatics, and the lymph is filtered through the lymph nodes, and it returns lymph to the blood. What is fascia? We say there is a fascia, and then we'll talk about the fascial system. But aphasia indicates a sheath or a sheet or any number of aggregations of connective tissue beneath the skin. And you can see the white area on this body. And when you look at atlases and pictures of bodies, you'll see the white area, which is the fascia. But typically when they do dissections, the fascia is taken away. So if you've ever gone to any of those displays of bodies, you will not see the fascia because it's been taken away. They didn't realize how important the fascia was. And it's white, fibrous connective tissue. It's very strong, it's very flexible, and it keeps the muscles and organs in place. It's really like in a building, it keeps everything together. A structure in the building, and it does play a role in interpreting pain because it is a sensory organ, and the fascia surrounds every muscle, every nerve, organ, blood vessel, and lymphatic vessels. And when the fascia doesn't glide, the nerves become trapped, creating pain. So sciatic sufferers have layers of the IT band, which is fascia, that gets stuck. And when there is stiffness and reduced range of motion, we get increasing chronic pain. In Derkham's patients, typically we'll see the SI joint in the lower back is really, really tight. And then fibrosis is formed when there is rigidity between the layers of the deep fascia. And we talk about the extracellular matrix. And the extracellular matrix which is in our connective tissue. All the cells of the fascia are immersed in the ECM. And of course, we have proteoglycans, glycosaminoglycans, elastin, fibrins, laminins, and many other glycoproteins in this extracellular matrix. And it plays a role in immune response. And we also talk about it as being ground substance. And when the extracellular matrix and when the fascia is really tight, we have pain and the lymphatics do not function properly. And so we now talk about the fascial system, whereas this is all together. We have solid fascia, fluid fascia, which is blood and lymph and cerebrospinal fluid, and we therapists work typically on the lymphatics. And then there's holographic fascia, which we won't go into, but that's very interesting to look at because the blood, the bones, the blood vessels, the cartilage all form part of the fascial system. So it is an interconnected fascial system. And in fascial world, we talk about biotensegrity, which is incorporating these liquid tissues of the blood and the lymph. And we want that flexibility and function. So there's a dynamic balance of tension and compression. And today we're going to talk quite a bit about compression and how important that is to the fascia and to the lymph. So fascia structure, it supports this matrix, this extracellular matrix. It's dynamic, it's innervated with nerves. It is considered a sensory nerve organ, and it's vascularized. It's responsible for proprioception, which is how you feel yourself in space, time and space, pain modulation. And in lipedema and Derkham's, we're always looking to see where is this pain coming from? What is happening? And so with fascia, we look at myofascial pain. And the fascia processes the health and diseases and is responsible for inflammation and fibrosis and neurosensory dysregulation. I'll be referencing Schleip a lot, Robert Schleip. He's one of the amazing researchers of fascia, and he works a lot with movement and body movement. I keep up with all of his research. And so now we have the fascia and the lymphatic system. So the fascia provides structural matrix and mechanical environment that supports lymphatic uptake and propulsion. And the fascia's integrity is essential to lymphatic health and vice versa. So when that lymphatic flow is not functioning properly, when there's too much stress or there is excess sugar or aging or not enough fluid, that fascia will get tight and then the lymphatics do not move properly. We have a superficial fascia, we have a deep fascia. We have a lot of research now on the superficial fascia, finding lymphatics in the superficial fascia. And I just recently found a very exciting study on the deep fascia. So you can go very deep into this whole process. But that superficial fascia is highly vascularized by blood vessels. And now we know that there are lymphatic vessels in it as well. Carla Stecco out of Italy was given a grant by the Lipedema Foundation to study the superficial fascia. That was so exciting to me when I heard that she had been given the grant. And then she presented on that at the International Fascia Conference that Adi and I had the privilege of attending. And then the lymphatics and the superficial fascia, so they run inside the superficial fascia longitudinally and transversally, and the collagen and elastin fibers within there guide lymphatic flow. I did a dissection to see what this all was because I wanted to know, what have I been doing? What have I been feeling all the time, all these 3-4 decades that I've been doing this? And it's very interesting to see the superficial fascia and the deep fascia. And so alteration of the superficial fascia affects the anchoring filaments of the lymph vessels, reducing their ability to drain lymph. And we know that when we do our manual lymph drainage, we are changing tissue pressures, and then we're stimulating those anchoring filaments to open so that the fluid can go into the tissue. And so now we know that the fascia is involved, and the elasticity and organization of this fascia or fibrous matrix affects lymphatic transport into the deeper lymphatics as well. And the lymphatic system is a sophisticated network of tissues. There are lymph vessels, lymph nodes, and lymph, protein-rich lymph. And of course, there are lymph nodes and lymphocytes and harmful bacteria. We know that the function of the lymphatic system is fluid balance. If we didn't have a lymphatic system, we would look like the Michelin Man, because it's in control of all the fluid balance, and also helping with the immune system as well as absorption of fats. And when we do our manual lymph drainage, I do a lot of whole body detox lymphatic drainage. We actually helping with that with the immune system as well. And so I put this together to show you the connection. So the lymphatic system is contained within the fascia. It relies on body movements, and the muscles in the fascia compress the vessels and push the lymph. And of course, we know deep breathing and compression affects the flow of lymph, as in pneumatic compression, as in deep movement, as in lymph drainage, as in negative pressure. And if the fascial system is healthy, the fluid will move freely. But any injuries, any inflammation of the lymph nodes, scars, our lymphatic system drainage will slow down, and then the body's not cleansed and your immune system is lowered. And when that happens, a person becomes susceptible to bacterial and viral infections. And over the years, we have found how important the lymphatic system is, and the work that we do, we realize it's even more important than we thought it was, because we are helping with the whole system of the body as well as the immune system. So to summarize, lymphatic flow can be promoted by fascial movement. Fascial restrictions can lead to lymphatic system dysfunction. And if we decongest, the lymphatics will flow. So when you do myofascial release, it's very exciting how you can actually help this. And so we want to understand types of connective tissue disorders. Today, we'll talk briefly on lipedema, which I could talk about for 10 years, and Deucker's disease. And we won't talk about Ehlers-Danlos today, but I just returned from the Lipedema World Conference in Rome, where there were just very, very exciting lectures on lipedema and all the latest research. Lipedema is a chronic and progressive disorder of fat metabolism. We also know now that it's also to do with the vascular system and its connective tissue. And there is a symmetrical fat accumulation, usually in the legs and arms, sparing the hands and feet. And there are painful fibrotic and nodular fat. There's easy bruising. Swelling will worsen with standing and by the end of the day. And it is often hormonally driven, where during puberty or pregnancy or menopause, you will see this manifest, but usually it has gradually been occurring. And lipedema is often misdiagnosed as obesity or lymphedema, but it is different than obesity and it is different than lymphedema. You can see the arms, when the arms are stretched out, we call those bat wings, which I've now changed the name to angel wings. And you'll see the bulges, and there's usually vascular as well. And there's painful fibrotic tissue in there, and the fascia is so involved. And how is the fascia contributing to lipedema? There's fascial thickening And that tension will irritate the nerves. And we know that there is pain in lipedema. There's not always pain, but most patients will have pain, sometimes upon palpation, or the pain will be all the time, systemic. Um, when there is swelling, the fascial adhesions restrict lymphatic flow, as I described to you in the slides before. When there is fibrosis, which we find in lipedema, that extracellular remodeling and nodular tissue contributes, and that's part of the fascia. And then the fascia, there will be mobility issues with a reduced glide, which limits the joints and tissue mobility. So we really need movement is so important. And I intend to live to be 100, and I'm already in quite a few decades in my life, and I just keep moving. I came from Pilates this morning, and I have lipedema stage 1, which did not progress. Lipedema is a progressive disease, but Nicholas Pennings, who is an obesity doctor, said to me, lipedema is a disease that can progress, so we can stop it. And so, in short, fascial dysfunction in lipedema will amplify pain, swelling, and restriction, and play a critical role in impaired lymphatic drainage and inflammation. And of course, inflammation is at the root of all of this. And when we have healthy fascia, everything's aligned and there's hydrated and there's a fascial grid, and that will support unrestricted lymphatic and interstitial fluid flow. When there is dysfunctional fascia, it will be twisted and dehydrated, and that will restrict the fluid movement, and there will be inflammation and pain. So I want you to remember this slide, maybe take a picture of this. So when I talk about the myofascial release, you'll see what we're doing and why we're doing this. And Derkham's disease, Derkham's patients are really strong, close to my heart, because we need so much help, and there's not enough studies and research and people talking about Derkham's, or doctors understanding it. And there are multiple painful lipomas within the fascia, and it's often associated with fatigue and cognitive dysfunction. There are actually 4 kinds of Derkham's disease. Some is just the lipomas in the fascia, and others is a systemic, all over the body pain, and oftentimes there's both. And then there can be a juxta-articular, which is in the joints, and the fascia is involved with that. Chronic pain, and often there's central weight gain. So it can be nodular, diffuse, mixed of the two, or juxta-articular. And we could talk about that for another 10 years. This was a little research, a little picture that Dr. Herbst actually did on Derkham's disease. And so you can see the areas of the body where there is Derkham's disease, and even in the scalp, you can feel it. But the hands, the buttocks, the neck, the scalp, and then generalized. And you will see usually in the abdomen, and there's be these lipomas between the ribs. But the fascial contribution to Derkham's disease is fascial rigidity and nerve entrapment, which leads to pain. And then there's inflammation, trapped cytokines, which are inflammatory markers in the extracellular matrix. And then the swelling will restrict lymphatic flow, and then that contributes to the immune burden and fatigue. So there's pain and fatigue from the fascial swelling. And so we say when fascia becomes restricted, healing is obstructed. And when we restore flow, we want to restore function. And metaphysically, we can look at that too. When the whole body is feeling restricted and you're stuck in your thoughts, everything will be restricted. So we need to work on the whole body and mind. According to Turkey, there was an interesting study showing how these fascial restrictors impair lymphatic and interstitial fluid clearance. And when we do our manual lymph drainage, we are clearing interstitial fluid. And this leads to interstitial inflammatory stasis, where these inflammatory markers and metabolic wastes accumulate in the extracellular matrix. So we've got IL-6, we've got interleukin-6, we've got TNF-alpha, and all the inflammatory cytokines. And then there's stagnation, and then that sensitizes the nerve endings for local inflammation and drives chronic pain. We have to find out why there is this pain and what we can do about it, because these patients suffer so much. Because Derkham's is a complex, painful connective tissue disorder marked by subcutaneous painful lipomas, chronic low-grade inflammation, fascial fibrosis and nerve entrapment, and fascial congestion with this low systemic inflammation with all these inflammatory markers and poor fascial glide. And that contributes to altered proprioception, sympathetic overactivity, and pain hypersensitivity. And if you speak to a Derkham's patient, they often will tell you that there may be days where they really have to stay home. They're in so much pain. This is one of the slides that I said I'm going to go quickly over, but I did do a comparison of Derkham's disease, inflammation and pain, and fascial involvement. I will give you a PDF of this, so don't worry. But Derkham's disease, there's painful lipomas in the subcutaneous fat, and in the fascia, the lipomas are embedded in fibrotic and inflamed fascia, so they are together. We have adipocyte dysfunction. We have immune activation with all these macrophages and inflammatory markers and cytokines, which I mentioned to you before, leading to lymphatic dysfunction. And so in this slide, I'm showing you how that happens. And that leads to neurogenic pain, where you have nerve entrapment in the fibrotic tissue, and the fascia is compressing and sensitizing the nerves. The pain is very, very real. So they're painful fatty tumors, chronic pain, which affects daily activities and impacts quality of life. So we need to help with the lymphatic system, and we need to help with the fascia to help release the pain for these patients. I found some studies showing evidence of fibrotic fascia around the Derkham's nodules and how these lipomas adhere to the fascia. And when Dr. Herbst once showed us pulling out, when she was doing research, a lipoma, and unless the tail is pulled out, it will grow back in again. So patients often cut out the lipomas, and they'll grow back again. The tail has to come out, but I don't know that all the physicians know about that. We really want to try and get to the root cause, but sometimes patients have to remove the lipomas because they are in so much pain. But the fascial restrictions and lymphatic dysfunction is very prevalent in Derkham's disease and in lipedema, because the fascia, if you haven't already gathered it, is a continuous connective tissue matrix surrounding the muscles and nerves, and this superficial fascia becomes fibrotic, thickened, reducing glide behind the layers, and then from that we get myofascial adhesions, which limit mobility and contribute to pain, and we have mechanoreceptors and nociceptors, and I'm going to go into more detail about that. And we have restricted fascial plane, and we trap these inflammatory cytokines. So it's very important to have lymphatic health and maintain lymphatic health. We know that there's inflammation in both lipedema and Derkham's, and they both involve low-grade inflammation. So through our nutrition, through our diet, through our lymph drainage, through our lifestyle, we need to manage that inflammation. And that's a story for another whole day. And here is a comparison of lipedema and Derkham's disease and fascia and pain. And the fascial involvement, comparing lipedema and Derkham's, and the pain mechanism, how these entrapped in the nerves, and also with the fibrosis. With Derkham's, they are angiolipomas, so they often have blood vessels with them, And in lipedema, it's fibrosis and thickened in the dermis. And then with lymphatic dysfunction in lipedema, we have leaky lymphatic vessels. And then in Derkham's disease, the angiolipomas will obstruct the superficial lymphatics. And there's a fascial remodeling that can take place. And this extracellular stiffness, there's a myofibroblasts within lipedema, and there's fibrotic thickening in Derkham's disease. When we do myofascial release, which we'll talk about, we will help to congest and clear inflammatory wastes. I warned you there was a lot of information. And so we know that there's lymphatic dysfunction and lymphatic insufficiency in lipedema. We know now that there is, and many studies are showing that, lymphatic insufficiency. And in after stage 3 lipedema, the patients can be progress to stage 4, which we don't call stage 4 anymore. It's lipolymphedema. But even in early lipedema, we know that there is lymphatic dysfunction. And so when you've got the fascia being really tight and pressing on that, we're going to contribute even more to inflammation. And the fibrosis in lipedema and Derkham's arise from the fascia, and there's the nerves are entrapped, and so myofascial release can soften the fascia and reduce pain. So in brief, fascial restrictions and lymphatic dysfunction contribute to pain, inflammation, and disease progression. Myofascial release softens the fascial matrix, helps that tissue glide, and decompresses the nerve endings. And AD will tell you we hold the tissue very gently, and we very gently soften into the tissue, and then we stretch the skin, and we improving tissue glide. And then we move everything and we soften everything. And then we do manual lymph drainage to remove that and enhance immune clearance and reduce the tissue clearance. So together, they both help the structural and fluid dynamics of these diseases. Manual myofascial release can reduce the fascial tension and improve interstitial flow and help reduce pain. And then the manual lymph drainage clears out these inflammatory cytokines and improve the immune system. Together, they can restore the biomechanical balance and enhance lymphatic flow, addressing the core dysfunctions in these conditions. And then we will help the free nerve endings and help with mechanoreceptors and sympathetic fibers. When I was studying at the Dr. Vada School, I graduated in 1992, and we were told that when we do our manual lymph drainage, we are stimulating mechanoreceptors. And when we stimulate these mechanoreceptors, it will send a message to the nociceptors to reduce pain. And so I never forgot about that. And when I started studying the fascia, I started looking deeper into that. So we're going to talk a little bit about these mechanoreceptors and how they help with pain and how we help together the two. And the treatment of inflammation, of pain, as I alluded to before, we do the manual lymph drainage and the myofascial release, the surgical removal, and sometimes lymph-sparing surgery, but it's got to be coupled with an anti-inflammatory eating plan. Sometimes there are other eating plans, but that's the basic. You can also do an anti-inflammatory keto plan, nature, meditation, and mindfulness to work on the whole body. I'm a clinical aromatherapist, so I incorporate essential oils to help the nerve pain and emotional pain, and then absolutely pneumatic compression. So it's a multifaceted approach. We are just going to be talking about some of the aspects of that. And so these two will synergistically reduce pain and swelling and stimulate superficial lymphatics to reduce inflammation. We enhance glial lymphatic clearance via cervical lymph nodes and the glial lymphatics in the brain, and we clear this lymphatic fluid beneath the fascial layers. And then the myofascial release will restore mobility and release the fascial restrictions. and improve interstitial flow. It's theorized that with the myofascial release, the alterations in tissue texture and tension resulting from this come from dynamic changes in the connective tissue and the neuromuscular system. So what is myofascial release? It's a manual therapy used to treat pain and restore movement by applying gentle pressure on the fascia. And you can see there, that's one of the hand movements that we do. It helps to break the pain cycle by relieving tension in the fascia and improving mobility. And by restoring motion, we can help individuals to have more mobility and reduce pain. We release the restrictions held in the body. We also know that unresolved trauma lies within the matrix of the connective tissue. So any traumas that we have had in our lifestyle, physical, emotional, get stored in the tissue. So it's not uncommon to have a real emotional release when we are working doing this. There are mechanoreceptors which respond to manual lymph drainage and to myofascial release. They're Meissner corpuscles, Pacinians, Ruffini, Merkel's disc, and free nerve endings. And the mechanoreceptors and the Ruffini are in the superficial and deep fascia, and they detect sustained pressure and release. And so when we do our manual lymph drainage and we're slowly pumping and releasing and giving that sustained release, what are we doing? We're stimulating these Ruffini endings. And John Barnes, who's one of my teachers, he said, I believe that many of the biochemical problems that people have come from fascial restrictions on a cellular level, and that a thwarted inflammatory response solidifies the ground substance, which can lead to disease. That's quite a statement. So working on this, we're working on the entire body. And when we are working on Pacinian corpuscles, they detect vibration and rapid pressure changes. So you can do foam rolling, kinesiotaping, you can do foam rolling with vibration. We do whole body vibration. There's many things we can do adding the vibration. So that will stimulate the Pacinian corpuscles. And this is another one of the busy slides that I didn't leave out because I wanted you to see it, but I put there in the chart what each of these mechanoreceptors do and how we have to have the slow, sustained pressure when we do our MLD. And that's why it's slow and it's sustained and it's pressure and there's a pumping, and then we can affect parasympathetic. The Pacinian corpuscles for vibration, primarily from manual myofascial release, and that helps with deep tissue and proprioception. And the free nerve endings with myofascial release and MLD, we're helping with pain modulation and sensitivity. And so manual lymph drainage, gentle rhythmic strokes, reduce swelling, we help immune function. We reduce swelling, we promote deep relaxation and stress relief because we're working to calm that nervous system. And Schleip introduced the concept of the interstitial inflammatory stasis, and the myofascial release and the MLD can disrupt the cycle, improving drainage. Fascia is not inert, it's metabolic and an immunological. So Robert Schleip's research frequently examines manual compression and natural movement as a key stimulus for fascial health. His primary focus is movement-based, but when he was talking at the fascial conference, he did allude to pneumatic compression devices as well. And he talks about biomechanical principles applied equally to mechanical methods. And so we know that mechanical compression devices could also help to influence interstitial fluid flow. And I'd love Adi to comment on this a little bit more. And we need more research on this. I'd love to see Schleip doing more research on this. But these studies show that mechanically applied compression can produce measurable changes in soft tissue behavior. The manual lymph drainage helps with vagus tone, helping relaxation and healing. And we could talk a lot about that. That's the psychological. I keep talking about the whole person, modulating the whole person and calming the nervous system. And the myofascial release together helps with the fluid dynamics. And when we combine the two together, we improve systemic inflammation and tissue healing. And then we restore mobility, we reduce swelling, and we can, together with the two, we can break the pain cycle and produce tissue healing. And then we can add pneumatic compression at home plus the diet. And so when you do it together, the myofascial stimulates lymph flow, the MLD stimulates lymph flow, and the myofascial releases restrictions in the deep fascia, helping with the tissue glide. And then complementary therapies are always important, such as gua sha, foam rolling, and you can also get vibrating foam rollers, massage gun, lymphatic cupping, massage balls, cold laser, deep oscillation, pneumatic compression, and then lymphatic cupping, which is negative pressure. And then what Robert Schleip has said is compression supports fascial hydration. It creates a sponging effect. It enhances interstitial fluid and lymphatic flow and helps with mechanotransduction, helping with collagen remodeling. And that pneumatic compression mirrors fascial loading cycles and complements the manual lymph drainage in CLT practice. There's some more studies here showing on the fact that fascia relies on cyclic compression for hydration and nutrient exchange, getting a sponging effect. And compression influences mechanotransduction. And pneumatic compression does align with this fascial research. And we need more research to show that, but it aligns with what he's talking about in his cyclical compression. And this will support lymph flow, reduce stiffness, enhance outcomes when combined with MLD. So we need more research, but the compression, whether it is in pneumatic compression or bandages or other form of compression as they use in sports, is very, very important. And Schleip's work shows that the fascia responds profoundly to compression, shear, and cyclic mechanic stimulation. And although his focus is on manual and movement-based modalities, these same principles apply to mechanical pneumatic compression, which can lead to fascial hydration, which will then support lymphatic and interstitial fluid and help with fluid. So you can see where I'm going with this. It's a combination. We have to have a multifaceted approach when we are addressing these diseases and these disorders. And so we have fascial nutrition and fluid dynamics. And pneumatic compression is a promising, biologically plausible approach grounded in fascial science. Of course, we need more clinical research, more with everything. And gee, I did that. I actually left time for questions. I cannot believe I did. I hope I didn't go too fast. But in conclusion, and I have 2 slides for conclusion, the fascia functions as a responsive elastic pump, essential to lymph propulsion, working in synergy with muscle movement and respiration. Fascial dysfunction can impede lymph flow, but manual lymph therapies, when applied thoughtfully, can restore fascial compliance, reduce pain, enhance lymph drainage, reduce edema, and support immune and tissue health. Myofascial release and manual lymph drainage are effective therapeutic techniques for connective tissue disorders because fascial restrictions plus lymphatic dysfunction equals chronic pain and inflammation. And so when we utilize these approaches, We enhance overall quality of life for individuals with connective tissue diseases. Intermittent, intermittent pneumatic compression devices modulate these fluid dynamics, reduce stiffness, and show promise that they will support fascial, and we know that they support lymphatic health. There's therefore significant improvement in patient outcomes and symptom management. I guess that was my last slide. So I thank you so much. I know that was a lot of material to cover, but I really am so excited that I could share this with you because it is my passion. And if anyone has any questions that we haven't answered, Adi and I will answer them afterwards. If you have any questions you'd like to ask me directly, this is my email. And thank you so much.
Linda Ann, thank you. Oh my goodness, that was a lot of information. And I'm frankly kind of astounded that there's only one question. So I'm hoping that if people have any other questions or comments, so you'll put them in the Q&A. I certainly have some comments, and here they come. Okay, so we'll start with this most recent question. I recently attended a webinar where the term lipolymphedema should not be used. However, you consider this name versus stage 4 lymphedema. Can you comment on that?
I definitely can, because there's a lot of controversy about that. We used to call it stage 4 lipedema. When Dr. Herbst was working with our ICD codes, they have insisted that we use the word lipolymphedema. So we're going back and forth between it. It is stage 4. It's the progression of lipedema from stage 3 to stage 4, or it is lipolymphedema. We are now saying lipolymphedema, so, and not stage 4. So, but it's not cast in concrete, but that's really where that came from. How do I stop the share?
That's a Jennifer question. I don't know, but I'm not seeing it anymore myself. So
Okay.
It's all set. I stopped sharing.
Okay, so, okay, because I can't see you guys, but that's fine. You can see me, right?
yep, we
Okay.
can see you.
Thank you.
So Renee writes that she's a massage therapist and does MLD and MFR, and that it's exciting to see the verification that the two work synergistically. I feel the same way, Renee. I am a massage therapist and was trained in manual in a myofascial release before manual lymph drainage. And it always struck me that the two needed to go together. So this was very exciting when I heard Linda Ann putting this all together. In terms of the sequencing, would you recommend to start with one of the approaches rather than the other?
It really depends on the situation, but I think that doing the myofascial first and releasing everything and then doing the MLD after that is very helpful.
That's the approach I tend to use.
Do you do that?
Yeah,
I
typically.
find it very challenging if someone's coming in for a 50-minute session and they're coming in for lymph drainage, incorporating myofascial. But if I have an 80-minute session, I can do a lot more.
Diana asks just lymphedema versus lipedema. Do you want to comment?
Yes, and I did not show slides on that, but lymphedema is very different. And usually it will be it's an abnormal swelling, usually in a limb, but it can be in the face if there's been neck and cancer. It is usually one area, and it can come from secondary as a result of surgery. It can be genetic as well, but it's usually one limb. So when you see the picture of the two together, you would know. So you have this large leg, which is lymphedema, and the other leg is normal. When you look at lipedema, the two are the same. The lipedema legs look the same. Lipedema, there is bruising, easy bruising and pain, not so with lymphedema. Lymphedema, the feet are involved, and with lipedema, the feet are not involved unless it is stage 4 or lipolymphedema, whatever you want to say, when there is lymphedema present. And those are the main differences. So it's very different. But as I said, we're now finding that there actually is lymphatic dysfunction in lipedema.
Yep. Yep. It's really exciting, all the research that's ongoing and coming out. And many things that we know can help with our lymphedema patients can also help with lipedema patients, but they are different
Yeah.
presentations.
And at the Lipedema World Conference in Rome, I mean, we had 850 people there from over 40 different countries. And it was 4 days. I mean, there was just research after research, and they were 10 to 15-minute talks, 11-hour days. I mean, can you
Oh,
imagine?
oh my goodness, I wish I could have been there. Um, Someone wants more specific training on working with connective tissue disorders. Renee is asking about that. Um, I know that I took a lot of John Barnes's courses myself, and I know you have, Linda Ann. I've also taken some of Eric Dalton's courses. Sadly, he's no longer with us, but there is a body of material. What else would you recommend, Linda Ann?
I'm just a John Barnes fan. You know, he's not teaching a lot anymore, but he teaches in Sedona. That's the only place he's teaching now. Um, there are a few other people. Oh gosh, what is the guy's name? T Lando,
Tyluka?
Ty Luca.
Yeah.
Thank you, Ty
Uh-huh.
Luca. But I don't know if she's referring to that or is she wanting to know about connective tissue diseases, as in lipedema and Derkums. I'm not sure.
Yeah, if you want to write a little more about what exactly you're trying to find out about, because a lot of this is stuff that we're all still learning about.
We're learning all the time, aren't we, AD? I
Yeah,
mean, the more you learn, the more you know how much you don't know.
yeah, no kidding.
And when you start going into the research, it's so fascinating because you get research and then you look at the references and then you go into that reference and you can be there for 2 hours going down a rabbit hole. And then suddenly you go, aha, that's what it is.
Mhm. You know, I want to just respond to Renee here. So Renee is really wanting to know all of this information, like how she can improve the well-being of her clients as a massage therapist. And I frankly think that the minute you put your hand on your client with good intention, you are improving their well-being. Uh, Learning massage techniques and manual therapy techniques and the particular situation in which you want to apply them, that's a lifelong pursuit. I've been doing massage therapy for 50 years, I figured out recently, and I feel like a novice. I feel like I'm still learning with every intervention. Do you feel that way, Linda Ann?
Absolutely. I mean, just absolutely it. You know, everybody that is there, every person, we're learning from them as well. And then if you do that and you're totally present to each client,
Yeah.
feeling what you're feeling when you're touching them and listening to them, there's so much that happens because it's so much more than what we're doing. It's so much more than manual lymph drainage, myofascial release massage. We are there present for that person to help them on every level.
Yeah.
And how often are we with somebody who's totally caring about us and present? It doesn't
Yeah.
happen.
No, no. I mean, really, I think that the interaction between a manual therapist and their client is a deep, profound, um, very intimate interaction. And that's why our ethics training is so important for us to make sure that we are constantly aware of the power that we have in the lives of our recipients. Um, Someone asked, Carissa asked if the copy of the presentation will be available. And yes, Sari, that's for sure. That is an NLN question and exactly how to receive it, but I believe a link will be sent out to everyone.
So it's not going to be the whole presentation. I'm going to do a PDF of those slides, of those with all the charts.
But the recording
Oh,
will
the
be,
recording, absolutely.
yeah,
Yes.
Yes, the recording will be available on demand, free on demand, or if you signed up today, it'll be available in the NLN classroom within about a week of today.
fantastic. I do want to comment again on one of Renee's comments, which is the trauma concept, because I think that was truly, it was something that Dr. Schleip said that made me want to really bring you on, Linda Ann, and present this. Because he talked about, we did a lot of talking about vagal tone and the effects of our interventions on the vagal nerve. But the ability of, and of course, I'm always thinking about pneumatic compression because I work with Eros and I love the intervention myself. But he talked about the ability to increase the parasympathetic response. So to affect the vagal tone in that positive manner with the use of pneumatic compression. And I had not heard that expressed, although I find that a massage with the pneumatic device is incredibly soothing. It certainly can't substitute for a therapist's hands, but it is dramatically soothing.
And I tell all of my patients, do your pneumatic compression at the end of the day when you finished your day. Relax, maybe put on beautiful music, do some meditation, do your box breathing, do the breathing we're teaching you. I have one client who she has a date with her husband and they watch a movie together, when she's on the
Oh,
pneumatic pump.
I
So
love that.
yeah, so that's what I tell, and it is very relaxing,
Yeah,
extremely relaxing.
it is very.
And then
Um,
going back to the vagus nerve and, adverse childhood events and the trauma in the tissue. And I train with Dr. Vada School. And when we open up the neck, after we've opened up the clavicle area, we work behind in the occipital ridge. And that's exactly where the vagus nerve originates. And when we do our manual lymph drainage, if it's done correctly, you are affecting parasympathetic release as well.
yeah,
You are reducing sympathetic and bringing up parasympathetic.
that's it's just lovely to think about that.
I
The
know.
profound things we can do. As Renee points out, there's no substitute for human connection. Teresa asks, this is interesting. If lipomas are present in the legs, is that lipedema or Derkums?
So it could be both. We don't know. It could absolutely be both. Usually with Derkums, I find a lot of the lipomas between the ribs, but a lot of times on the arms. If it's on the legs, it can be lipedema. It could be Derkums as well. The Derkums have it there too. So there are other symptoms with Derkums that would be different than lipedema, but many Derkums patients have lipedema as well.
Mm-hmm. That's something we always have to remember, that these conditions can be combined. Lymphedema and lipedema can be concurrent, whether it's stage 4 or not. And so lipomas are not always Derkums. Is that true? That someone asked about that.
Yes, because there is something called familial multiple lipomatosis, which is FML, and there's no pain with that. And I just had an email from somebody, and I have to get back to her, and I really think she has Derkums disease. She told me about all these lipomas, and she'd put on weight, and in the family, someone in the family has got some lipomas. So often I'll ask the person, did anyone in your family have lipomas or even one lipoma? And I found often the father had one or two lipomas and they weren't painful. So that could be FML, which is familial multiple lipomatosis. And then there can be Derkums. The Derkums is painful. And as these lipomas manifest, they are very painful.
I remember Dr. Herbst saying something about the pain in the lipomas having something to do with a vascular connection with them.
Right. Yes. Because there are lipomas with the vasculature, the angiolipomatosis.
Mm-hmm.
Yeah. And then see the fascia is all connected with that and the nerve endings. And so we need to find out more about where is this pain coming from, why. And that's why I started being so fascinated with the fascia.
Yeah. I can answer a couple of questions from Carissa and from Renee here. We did address a little bit about EDS and other issues that are also connected with lipedema and Derkums. There could be a presentation on EDS from Eros in the future and possibly from NLN without it being Eros provided. We did a presentation that I think is probably available on YouTube in conjunction with the Fat Disorders Resource Society this past spring, I spoke about the connection between Ehlers-Danlos and lipedema based on a case study with a client of mine who is very interesting and very open in sharing her story. So that's a really important point, because these connective tissues disorders are broad. And when you talk about Ehlers-Danlos syndrome, my goodness, you're talking about a huge number of presentations, although we most frequently are aware of the hypermobility related version of that. So, and I got to go to Rome and present on that a couple of years ago. That was pretty exciting.
And then with these disorders too, there's often mast cell activation syndrome. And so there are other comorbidities that go with those, and lots of gut issues, especially with the Ehlers-Danlos.
Yeah. And I would recommend, if you're really interested in that, there is information out there that's vetted. So if you look at the Fat Disorders Resource Society YouTube past presentations, I know you have some there, Linda Ann and Dr. Herbst, and I'm on there. So that's really helpful stuff. And then I know the NLN, if you're a member, and if you're not, it might make sense to become one, because there are numerous presentations that will help you dig deeper into these topics.
And I recently heard a talk with Dr. Campisi from Italy, from Milan, and he did a study with comparing CDT, complex decongestive therapy, with patients, and then another group with CDT and pneumatic compression. And they found a 70% improvement with the ones that did the CDT plus the pneumatic compression. So I just thought I would talk about that. That was very interesting. And
I appreciate you bringing that up, because he has been a proponent of pneumatic compression, and in using it in advance of surgeries in advance of surgeries. So I hear a lot of surgeons recommending it post surgeries, but he finds that it helps the patients have an easier time and a better outcome, faster healing, with having the system, the lymphatic and of course connective tissue system, in the best tone that it can be in before these pro-inflammatory interventions such as surgeries occur. And I just think that's really important to keep in mind too, that none of us is going to be able to perform an extensive manual lymphatic drainage on a daily basis or a twice daily basis in the way that might best benefit us. So that's where I think the devices come in very handy.
Because you're not just working the arm or the leg, it's affecting the pelvic area, it's affecting the ribs, it's affecting the whole body.
Yeah.
And he was pointing that out in this talk.
Yeah, that synergistic effect of one of my instructors back in the day said something to the effect of, with lymphatic therapy, when you treat any part of the system, you treat every part of the system. And
Yes.
while that is an oversimplification of how that works and may not be the most efficient thing, if I've got an arm lymphedema and I'm working the legs, it is still so true that it is a full body system, and that by even just touching anyone anywhere, if we increase their respiration, improve their well-being.
Yes, and helping lymphatic flow, because even if it's not the exact lymphatic pathways, you're still affecting the entire body.
Yeah.
And I remember I worked on somebody several years ago who'd had his arm cut off. Sorry, what was the terminology?
Amputated.
Amputated. I'm sorry, my brain's busy with my
You're thinking fast.
Yeah, I mean, I amputated, and so I worked on the stub, and then I worked on the arm that wasn't there, and he got great relief. And then I worked the contralateral side. So yeah, if you affect the whole body,
including the brain. So that is really, that's important stuff. Looks like we're running out of time here.
Unfortunately, I wish we could continue, because this is an amazing conversation, and I just love how, how much there is to continue to talk about it. And certainly it demonstrates the need to continue to talk about it. And I hope that, we can continue to bring more on these topics, and maybe some hands-on, training in the future. Absolutely.
we
So
need a whole talk on the brain, don't we, AD?
Oh, we do. Well, we can scheme on some more presentations to offer in the future. So thank you to Jennifer and the NLN for allowing us to share this important information. And thank you, Linda Ann, for putting this amazing presentation together.
Thank you guys so much.
Absolutely. It is our pleasure. And thank you to Eros Medical for supporting the NLN, and Linda Ann and Adi for being here today and again sharing this amazing information. If just